The broadcast is now starting. All attendees are in listen-only mode.
Hi, this is Gary Swartz. Good afternoon. Welcome to the American Academy of Home Care Medicine's webinar on the 2015 Medicare Final Physician Payment Rule and Home Care Medicine. We're going to be covering a number of topics this afternoon. We'll go over some highlights from the 2015 Physician Payment Rule, and then want to touch base on other home care medicine topics of note. What is going away that you need to know? A couple aspects from the home health final rule that'll take effect in 2015. Mentioned a development called the Impact Act that was signed into law October 6th. Talk about a new CMS initiative, that provides for practice transformation grants. I mentioned the annual meeting and take questions. A couple of caveats for this afternoon. We're going, this information that we're going to cover about the final rule, in particular about the Chronic Care Management Code, we're going from the final rule and its incorporation of prior rules and regulation, and then what the code language itself says. Medicare has not yet published its instructions, its detailed instructions to its contractors around the country, known as the Carrier's Manual instructions. When they do that, we'll identify that and provide you updates with that information and webinar as necessary. But again, the opportunities present themselves for 2015, so we wanted to get up and running this afternoon. Also, there's we're going to be posting this material. Please share comments and questions so that we can follow up. Okay. In terms of follow-up, we do want to let you know of the Academy annual meeting in the spring of next year. It'll be much warmer and beautiful, hopefully middle of May near Washington, D.C. The annual meeting will include high-level keynotes that are fundamental to the field, really high-level, powerful presentations this year, provide even more evidence of the value of home care medicine from the field areas of ACOs, IEH, and managed care. There'll be discussions regarding effective care models and care neighborhoods, expert sessions that have been introduced in the past years, covering a variety of practice topics in the mornings, then the interactive interest groups at lunch, the wonderful networking with your colleagues, more and expanded exhibits and sponsors to support your practice. So bring a colleague, a clinical colleague, management colleague, and both. Okay, moving on to the final rule highlights. We're going to talk about the value-based payment modifier program, advanced care planning, telehealth, removal of the employment requirement for incident to services at rural health clinics and federally qualified health centers. Mention the modifier that's coming on board to indicate when you're providing services out of a provider-based department. Talk about this topic of transition of the 10 and 90-day global packages into 0-day global packages, and let you know what that means and implications, and then spend some time on the Chronic Care Management Code and preparation for your rendering that service, documenting it, submission of claims, and getting paid. The value-based payment modifier. This is a value program enacted in the ACA. It applies to the Medicare fee schedule payments. The value-based payment modifier will bonus or penalize practices according to quality and cost measures reported 2 years prior in comparison to one specialty. So, for example, it's beginning next year, 2015, based on 2013 data received by CMS for practices of 100 or more. The program is going to add or move down to practices 10 to 99, and plus those above 100 beginning in 16, all on 2014 data, and then move to solo physicians in 2017 based on 2015 data, and we'll talk about that a little bit more. CMS was going to add nurse practitioners and physician assistants to the solo providers and group providers reporting and being impacted by the value-based payment modifier in 2017 as standalone practices, but is holding off doing that until 2018. CMS is implementing this new program, the value-based payment modifier program, with the PQRS measures and approved proxies for ACO participation. That'll be used to develop what they're, in a sense, is a quality numerator of the quality over cost calculation to come up with the bonusing or the penalty provisions. CMS has also modified the amount of bonus or penalty that will apply to the value-based payment modifier program. And rather than just being a sheer percentage of a payment on each service as happens in these incentive programs, rather there's going to be a pool of funds that is available from those programs that have been penalized, and those dollars will be distributed over those practices and eligible providers that are being bonused over the program. So before it is all sorted out, it may be below 1% or equal to a percentage, or it may be above a percentage. Right now they're calling it 1x or 2x, et cetera, number. Again, the quality portion of it is going to be based on sending in and the results of PQRS. The cost measures, that it's again going to serve in a sense as a denominator, is the per capita cost of Part A and Part B, and then per capita costs for beneficiaries of certain chronic conditions, and you're familiar with these. And then there's going to be a Medicare spending per beneficiary, or MSPB measure, as well as a cost measure. In a sense, the grid of how this is going to look like for different provider groups as of 17 is presented here. For the first year, there's not going to be negative adjustment, again, if PQRS is reported. That's why you want to make sure you're doing that now and on an ongoing basis, because it affects not only the PQRS payments, but it also feeds into this payment system, and it'll affect and further reduce your payments here or opportunities here if you're not reporting. So as of 2017, for solos and groups 2 to 9 eligible professionals, the opportunity, for example, if one was low cost and high quality, using those quality and cost criteria that we just took a quick look at, can earn up to 2x of what those available dollars would be. If someone did report PQRS, but was low quality and high cost, they wouldn't move up or down in this initial year, moving down to solos and 2 to 9 eligible professionals. For the groups of 10 or more, as of 2017, again, this is the result, and there's additional bonuses or penalties that are available. They will have had a longer track record of experience beginning in 15 and 16, and so the program, in a sense, is going to be more fully implemented for them by 2017. Again, it was the moving down of group size to solos that's occurring from 15, 16 to 17. Again, we want to heighten awareness of this. We'll talk more about this at the annual meeting next in the spring as well. The important thing to be aware is that it's going to affect all providers, physicians as of 17, and then again including nurse practitioners and PAs as of 18. Our concerns about the value-based payment modifier program. The value-based payment modifier program compares one's performance to one's specialty. And as we know, with your services in the home and assisted living facilities with those that are the sickest and most costly beneficiaries, that your patient population is not that of your same specialty in the office setting. There is risk adjustment built into the value-based payment modifier. Our concern, the last bullet point here, is that that's not adequate for the multi-morbid high-cost population. There's a growing body of research that is showing this and demonstrating this as well. The issue or the challenge for the Academy on your behalf is that our documentation and demonstration to CMS is they want us to be the moving party, and that is going to cost dollars and take a great deal of activity and analysis. And then the other observation is that the PQS measures, as we know, lack relevance to the multi-morbid, and we hope to bring on some measures in the future years that are more relevant to your population. Advanced care planning, service that you may already be rendering. CMS took a look at that this issue for this year. However, they've determined not to cover and pay for advanced care planning as a distinct standalone service as of 2015. CMS has adopted 2 CPT codes to describe advanced care planning. Those are provided here, one the base sort of code, and then an add-on code for each additional 30 minutes. CMS, in the final rule, has provided that they will consider whether to pay for CPT codes, for the advanced care planning codes, after they've had the opportunity to go through notice and comment rulemaking. What we're aware of, the Academy has worked to encourage CMS coverage and payment of this service. As you probably are aware, there have been major articles in the national press regarding the benefits of advanced care planning and the respect for and documentation and respect for patient preferences. There is a political element, as we know about from a few years ago, to the coverage and payment of advanced care planning, and that may have affected a determination of whether to cover it and pay for it as of 2015, and hopefully things will resolve themselves that this is a service for which you're paid for on a standalone basis in the near future. Telehealth. Telehealth as a service under the Medicare program requires meeting various elements that don't seem to be in place for the benefits, general benefits of the Academy members. It requires a geographic setting for the beneficiary in the certain designated areas, the rural and medically underserved areas. It requires use of certain communication technology, just in terms of the way that communication goes back and forth. And then lastly, and perhaps most importantly, that one has to be designated as what's called an originating site of service. To date, the home and assisted living facility locations are not originating sites of service, as are other locations, such as hospitals, settings, etc. Due to that reason, that generally speaking, again, the home and domiciliary locations are not approved originating sites of service. That said, do want to bring to attention that CMS did finalize an increase to the list of services. It does pay when that the previous criteria that we just discussed is met as telehealth services. These are the psychotherapy service codes here, prolonged service codes, and annual wellness visit codes. Again, we have an originating site of service issue. We bring that to the attention of CMS, and we're informed that that is outside of their jurisdiction and is really a matter that Congress has reserved to itself. So again, our activities and efforts would be directed to Congress in the telehealth area. An item of note for those practicing in or relating to rural health centers and federally qualified health centers, and also has a relationship to the Chronic Care Management Code we'll be reviewing in a moment, is that the employment requirement for Incident to services has been liberalized or eliminated for that location. So, for example, a nurse going out at the direction of a nurse practitioner or a physician in one of those settings to have their services paid for under the Incident to provisions relating to the treatment plan that had been in place required that individual to be an employee of the center or practice, and that's been eliminated. So the benefits here, and again, will be in place for the Chronic Care Management Code and Transition Care Management Code as well, is that different organizational arrangements can be established. You can establish relationships with individuals in the community on a contractual basis, as long as, again, they're relating to your direction and supervision relating to the care plan, but they would not have to be employees of the center. And as relates to the Chronic Care Management Code and to Transition Care Management Code, they don't have to be an employee of the practice. The topic of resource-based practice expense RVUs and off-campus provider-based departments, CMS is working towards a policy of payment of a service at the least costly location that service can be rendered. We can immediately recognize that's a benefit to the services you provide in the least costly location. That's also supported by MedPAC. It's also supported, part of the provisions or thinking behind what's called the Impact Act. We'll go over toward the end of the presentation. And CMS at the same time is concerned that given the number of provider practices that are now being acquired and put into employment ownership by hospitals and health systems, that what they had been paying for before previously in terms of your services on a non-facility basis, now that you may be located and rendering those services at a facility. So beginning in 2016, there's going to be the mandatory use of a modifier to indicate more specifically when those services are rendered in provider-based space. We'll touch on this more next year, just as a highlight, to make sure that staff and revenue cycle support organizations are well aware that your services that are outside the location that are rendered in the home and assisted living facilities nonetheless should be submitted and paid for on a non-facility basis, despite the fact that you organizationally may be relating to or employed by a hospital or health system. CMS is concerned, you may be familiar through practice, through your training, through, fortunately and unfortunately, through our own experience of receiving procedures or going through operations, that Medicare has a payment policy where it's bundled the pre-operative services or pre-procedural services and post-procedural services in terms of evaluation and management services into the global packages and payment models. For minor procedures, that's a 10-day window, and for more major procedures, that's a 90-day window. CMS is concerned now that as we move into a more bundled environment, that what is in place get evaluated. So essentially, they have finalized provisions that they are going to deconstruct these payment packages that are in existence, beginning with the 10-day package in 2017, and then the 90-day global packages in 2018, then the procedures are going to be paid for on a standalone basis, and then the pre-evaluation consultation, the determination to have surgeries, etc., and then the post-operative follow-ups will be paid on a distinct claim submission, evaluation, and management basis. CMS is concerned that the values of that pre- and post-work, they want to see how that, again, compares to what they've been paying for as bundled in terms of all the services together. And they also want to make certain that all the services are rendered that had been prior described to be bundled pre and post. What the topic here for Academy members, and I guess what I'm throwing out there is why I think this matters. There's a payment reason and there's a care reason. This is going to be put up to 14% of the fee schedule into moving around in these outer years of 17 and 18 as CMS evaluates those packages, deconstructs things, values again, and then rebundles. So the opportunity may be there for primary care to recapture some of the value of those services. From a care perspective, so there's a payment implication. From a care perspective, just want to be observant that, again, there is the appropriate follow-up care, not a disincentive for that follow-up care as services get unbundled, and that you see your patients in transition, aspects after discharge in a condition without the follow-up that they should have received from the proceduralist. Again, this isn't an assurity that that's going to occur. One would hope that it's not. It's just just some thinking. Also, the opportunity as this begins to unfold, it may be another opportunity for the field of home care medicine to approach facilities with your transition care management services and follow up strengths and communicate those services to those facilities as a value that you can provide. So again, more opportunities for the field to participate in the delivery and payment for services that you render. Okay, so moving on to the chronic care management services. A new CPT code is adopted and will be covered and paid effective 2015. The information we're about to review is based on the final rule. It incorporates previous rules and regulations on the topic from CMS, and we'll also discuss the code description. Again, as mentioned, the Medicare instructions and carrier's manual materials to follow once they're published. We'll provide updates and other educational form. This is, before we get into the details, this is my be careful out there, Hill Street Blues moment. As you know, compliance plans are now required by the ACA. The days of voluntary compliance plans are over. We want to make sure that there's, again, you establish a compliance and risk management culture in addition to compliance plans. Encourage the provider-patient relationship, that be established and understood, and it's a feature of the chronic care management service as well. For you to be the primary care provider of record, this is critical for fee-for-service care management coverage and payment, and it's going to be required for ACO, and is required for ACO, shared savings program attribution, in addition to plurality of services, et cetera. But you really want to make sure that that relationship is established and documented. Drilling down that the medical necessity each visit is established. Again, medical necessity is not a requirement in the preventive and screening services, but for those based on medical necessity under Medicare Part B, that does need to be established each visit. Again, that's that in lieu of an office visit. Also concept and should be there up front and early in the your notes. Document, that drives the selection of the evaluation and management service based upon the components of the history exam and medical decision making. The chronic care management code and transition care management services, again, we're documenting and focusing on the non-face-to-face time. So that's the benefit and the opportunity now of these services, that they finally recognize all that time and service that you're rendering non-face-to-face with the patient. So some ways to do that. You may want to consider some start and stop time, policies and procedures for entering the notes of those of your staff and yourself to indicate your rendering and documentation of the service. It needs to be 20 minutes on a monthly basis, and we'll go over that in a little bit more detail. And again, your EHRs may have features of time stamps when notes or services is entered and exited, etc. Want to work toward accurate and complete diagnostic coding. This is important as we move to more risk-based payment systems, and as mentioned, it's even a feature of the value-based payment modifier. Questions come about EHR requirement for the chronic care management service, and there is a requirement that whenever the chronic care management service or discussion references the health or medical record, that an EHR that's certified at least to the 2011 approved standards is in use. Where you're in practices where multiple EHRs may be in use, and one is certified, one is not certified, the one that is certified governs and must be used. Okay, so the CPT code is 99490, again, covered and paid effective 2015. At least 20 minutes of clinical staff time directed by a physician or other qualified healthcare professional per calendar month, so it's a monthly service. Again, also available, of course, to nurse practitioners and PAs. This can be personally rendered service, non-face-to-face, so you can be working on your own and have your services covered and paid. The following requirements, again, this is from the code language: 2 or more chronic conditions expected to last at least 12 months or until the death of the patient, and that these chronic conditions place the patient at significant risk of death, acute exasperation, decompensation, or functional decline. That a comprehensive care plan's been established, implemented, revised, and monitored. You probably recognize these conditions in each of your patients, and one would think that if you wouldn't be doing house calls if your patients do not meet this patient eligibility. And again, you're likely rendering this 20 minutes of non-face-to-face time, or that of your staff is rendering those services for many of your patients already. CMS recognizes that this is their first initiative, if you will, to pay for comprehensive care management services and care coordination on a non-face-to-face basis. Their language in the final rule to evaluate the service, to assess whether the service is targeted to the right population and whether the payment's appropriate for the services being rendered. We know that many of your patients are far sicker, have far more chronic conditions, et cetera, and you're providing much more than the 20 minutes per month. This is CMS's starting point. And CMS will consider whether the service meets the care coordination of Medicare beneficiaries, and if not, how best to address the unmet needs. And again, that would we're working on that. We'll discuss more in a few moments. And that would certainly support your services in an even more meaningful way. Elements of service, again, the slides will be posted. This is CMS's discussion in the final rule of the elements of service. We're going to deconstruct, we're going to take these apart element by element in a moment. Just want to let you know that they are there. Similarly, regarding the electronic health record requirement, I've bolded those elements that CMS believes references or, in a sense, touches the care plan, and those items are here bolded. Here they're broken out for specifically, and again, we'll note those in a moment. Okay, so moving on to the specific elements of service and things that you have to prepare and get ready, and in terms of organization and documentation for next year. Access to care management services. So the first element is providing the beneficiary with a means to make timely contact with you or a member of your practice to address his or her urgent chronic care needs, regardless of the time of day or day of the week. Again, the individual does not have to reach a licensed physician, nurse practitioner, PA directly, but they have to be able to have that ability to make contact with you 24/7, or someone affiliated with the practice, and we'll get into that in more detail. Continuity of care. With a designated practitioner or member of the care team with whom the beneficiary is able to get successive routine appointments. So again, that established relationship. And we're at the elements levels beyond the coding description. These are the elements that CMS requires to see. CMS had proposed standalone distinct practice standards or requirements. They thought that their elements and discussion of what was required would be sufficient. So in a sense, there is no standalone certification, credentialing, accreditation, etc. for the chronic care management code, but the elements have to be established, and certainly upon medical review and the audit available for CMS to be able to document and see. Okay, so we've done the continuity of care, systematic assessment of needs. We're going to have care management for chronic conditions, including a systematic assessment of the beneficiary's medical, functional, and psychosocial needs. That's going to include a system-based approach to ensure timely receipt of all recommended preventive care services, and medication reconciliation with review of adherence and potential interactions and oversight of beneficiary self-management of medications. Again, services you're likely already rendering on a routine basis. Again, as we could tell from the code description and the minimal number of minutes that are required to satisfy the 20-minute threshold for coverage and payment, that this service is available to all providers where the beneficiary meets those conditions. So it's going to be used in office settings, outpatient office, in facilities, etc. Okay, creation of a patient-centered care plan. This is one where that certified EHR requirement is in effect. So an element is the creation of a patient-centered care plan based on a physical, mental, cognitive, psychosocial, functional, environmental assessment, and then reassessment of the patient, and an inventory of resources and supports, establishing a comprehensive care plan for all health issues, and that care plan would be shared as appropriate with other practitioners and providers. We've done we've conducted a webinar on the care plan previously. Those materials should be posted to the site, and we will revisit that and do another level and touch on that at the annual meeting, and also do another webinar on the care plan itself and its involvement in these payment models in the future. Structured clinical summary record. structured recording of demographics, problems, medications, medication allergies, and the creation of a structured clinical summary record. Again, this is another element for service that requires the use of the certified EHR. This would include a full list of problems, medications, and medication allergies in the EHR, and this would inform the care plan, care coordination, and ongoing clinical care. And that's why there's also the interest in having that in the electronic and available format.